based on the emerging data and then therapeutic options. So first, I'd like to mention a couple of points about the structure of COVID-19. So some of these aspects are important to understand, so you can basically know where the treatment options are coming from. And so essentially, the virus has spike proteins on the surface. So these are the spike proteins in lavender. And these spike proteins essentially attach themselves to the host receptor, ACE2, so angiotensin converting enzyme 2 receptors, and that's how they gain entry into the cells. So nobody really knows where the virus came from. It is thought to be perhaps related to bats, but that is yet to be confirmed. Nobody knows what the intermediate host is either, so that's all still up in the air. So I'll just show you some of the, it's a phylogenetic analysis about coronaviruses. So essentially you have the alpha coronaviruses, beta coronaviruses, and then there are different types of beta coronaviruses. So you have A, B, C, and D. And then there's gamma coronavirus as well as Delta. So coronaviruses, the ones that are causing the outbreak are essentially beta coronaviruses. This is an older phylogenetic analysis, so it's a tree of different coronaviruses, and you can see how many different coronaviruses there are. And just to correct a misnomer that we started noticing with the MERS outbreak, where people would panic when they realize that a patient has a positive multiplex respiratory panel for one of the seasonal coronaviruses. And so there are multiple different coronaviruses. And as I'll discuss later, only 3 has proven to be related to an epidemic or cause an outbreak. So essentially here you have the MERS-CoV, and then the SARS, which caused an outbreak in 2002, 2003, and then you have the 2019 coronavirus, or the SARS-CoV-2. And so this is the 3rd coronavirus outbreak over the past 2 decades. It is more genetically, it bears larger genetic similarity to SARS virus compared to MERS-CoV. And so just looking at the timeline between the SARS outbreak in 2003 and the COVID outbreak in 2019, 2020, it is very interesting to see the differences in the response worldwide. So the first case of SARS-CoV was identified in China in November, and then it was first reported to WHO in February, and the global alert was issued in March. The virus was identified in April, so it took a good 5 months to identify the virus, that it's novel. And then there were a number of cases worldwide until finally it was declared contained by the WHO in July. Things moved at a much more rapid pace with the COVID-19. So essentially December 8th, the first case was identified, reported to the WHO 3 weeks later. And then a month after identifying the first case, the virus was identified and genome sequencing was done. WHO issued a global alert declaring a public health emergency by the end of the month. So it took less than 2 months before it was declared a public health emergency. And then, and the world has really changed. So this is a nice graph comparing SARS-CoV with MERS and SARS-CoV-2 in terms of number of cases and deaths. So if you look at this bar graph, in blue is the total number of cases, and in red, the number of deaths. And so if you look at the percentages, you'd notice that MERS-CoV was the deadliest of all the other coronaviruses, with a mortality rate of 34.4%, compared to 9% in SARS and then 2.8% in SARS-CoV-2. And so if you just look at the B section of the diagram, you'll think, well, it's not that bad. But the reality is the denominator of SARS-CoV is much bigger than that of MERS and SARS-CoV. And so the absolute number of deaths remains higher. And so this was released by the Saudi MOH today. And so essentially they have daily updates on what's going on in the world and what's going on in Saudi Arabia. So we do have over 2 million cases worldwide with 160,000 deaths around the world. In Saudi Arabia, there's 9,300 cases. And then you can see an increase in the number of cases identified in Saudi Arabia. But that does not necessarily reflect a worsening situation in the country. Rather, it reflects a more intense mass screening that's being done by the Ministry of Health and the Public Health so, to facilitate the containment of the virus within the country. So again, looking at the differences between the three coronaviruses, and so we all know that MERS was first discovered in Jeddah, Saudi Arabia. That was where the first case was reported. And then possible natural reservoir is bat in all of them. And then in terms of receptor where the virus would attach itself to the host cell and gain entry is essentially the same in both SARS viruses. And because of the similarities between the SARS virus and the virus that causes COVID-19, the virus that causes COVID-19 is called SARS-CoV-2. And if you look at R0, so this is an important factor in determining epidemic potential of the virus. So this essentially means that for each confirmed case, you're likely to transmit infection to 1.4 to 5.5 individuals with a SARS, less than 1 with MERS, and then 2.2 to 2.6 with SARS-CoV-2. So essentially, on average, each infected patient with SARS-CoV-2 is likely to transmit an infection to 2 to 3 individuals. Now, this really explains the intensive measures taken by most governments around the world for social distancing to try to drop the R0 as low as possible. In terms of clinical manifestations, we have quickly come to learn some of the clinical manifestations. One of the largest cohorts published was a cohort of 44,000 from China CDC, where it showed the vast majority of patients presenting with fever. Again, we all have to be aware that in one of the cohorts, only 83% had fever, so you have a good 17% presenting without fever. And that is something that we have noticed with MERS as well, and that has essentially led to revision of the MERS-CoV case definition at the time. There's also cough, that's fairly common. GI symptoms were initially noted to be uncommon. However, recent data are suggesting GI symptoms in the form of diarrhea, abdominal pain, and or vomiting in 20 to 50% of cases. In terms of case fatality rate in China, it's about 2.3% of deaths, staggering difference when you categorize patients by age. So there's this sharp increase in case fatality rate in patients that are above 80 years of age. And then with healthcare personnel infected, about 1,700 healthcare workers were infected during that initial outbreak in Wuhan. Most of them were in Wuhan. 14% were severe or critical, and there were 5 deaths. So the relative low number of case fatalities within healthcare workers may be related to early recognition and implementation of supportive therapy, or it probably is related to the fact that healthcare workers tend to be younger and possibly have lower comorbid conditions. And so again, this is a nice illustration of fatality rate by patient age. And so you can see it's virtually 0% or close to 0 in young children. And then it starts going up as soon as a patient is above 50 years of age. And then it reaches a high mortality rate in those above 80 years old. Some of the interesting data that emerged from Italy, which was one of the countries that were hit really hard with COVID outbreaks, was the relatively higher rates of case fatality in the same, if you compare the same age category with that of China. Nobody really understood why. It could be that there are some ethnic variability, which would allow for some genetic determinants that would place Caucasians at a higher rate of mortality compared to Asians, or difference in access to life supportive therapy is very difficult to speculate at this point, but this was an interesting observation. And so in terms of comorbidities that would be related to death, there's hypertension, diabetes, coronary artery disease, chronic obstructive lung disease, chronic kidney disease. All were found to be higher in non-survivors compared to survivors. And then laboratory findings, abnormalities in ALT, very high LDH, very high troponins, D-dimers, and interleukin-6 level. But on a multivariable analysis, and so that's what you really want to look at, each increase of age by 1 year would be significantly associated with higher risk of death. Same thing for SOFA score. So a higher SOFA score indicates a more severe illness. And so it's not surprising that it is associated with higher risk of death. Same thing for D-dimer. And then if you look at the change in laboratory markers, so in red, you have the non-survivors, in blue, you have the survivors. And so the non-survivors tend to have worsening D-dimer until their final outcome. They have a lower lymphocyte count and lymphocyte to neutrophil ratio. They have higher interleukin-6 levels, and we'll come to that in a second. They have higher serum ferritin levels, and so we all know that serum ferritin is a acute inflammatory marker, and so it is non-specific to COVID. Most of these changes are in fact non-specific to COVID. You could see them with certain viral infections and with severe cases of sepsis. Higher troponins were noted in non-survivors compared to survivors. Same goes for lactate dehydrogenase levels. So this is another interesting graph. If you look at this, there's a lot to be learned from this figure. And so essentially, you notice patients presenting, both survivors and non-survivors alike, present with fever and cough initially. And then they start presenting to hospitals and they start developing dyspnea around the end of the first week. And then around day 9, so 2 days after their shortness of breath, they start exhibiting signs of sepsis and ARDS. And so invasive ventilation and ICU admission happens around day 11 or 10. Some of them receive systemic steroids. And then some of the noted things as well is that patients who die of COVID-19 tend to continue to shed the virus until their death compared to the ones who recover, where you can see with the lavender blocks, they develop a negative, sorry about that. They develop a negative PCR on repeat testing before their discharge. And of course, once they're on an invasive ventilator, their mortality rates go up, unfortunately. So it is important to know that if patients are caught very quickly once they develop symptoms, it is important to bear in mind that they might deteriorate around the end of their first week. And so this is a nice breakdown for how patients present. So you can see about 1/3 of patients would have no symptoms. And so this is really arbitrary because the true denominator of asymptomatic people with SARS-CoV-2 is really unknown. Most countries have had problems with access to swabs or testing kits, and therefore there hasn't been a lot of mass testing. And once there's increased testing, you see increase in the rates of positive or confirmed cases, even the asymptomatic ones. And so that's something we're probably going to start seeing in Saudi Arabia, which is actually a good thing, that once you identify a case, they'd be more vigilant with isolation and reduced transmission as a result. About 50% would have mild to moderate symptoms, and so upper respiratory tract infection symptoms, things like that. And then severe symptoms and critical would present in about 15% of patients. And so death rates would be highest in the severe to critical patients, as expected. And so I'm not sure if this projects well. This was taken from the WHO website. They define severe pneumonia as O2 saturation of less than 93% on room air, and then ARDS, where you essentially have patients ending up on the vent with PO2 FiO2 ratio starts at a level below 200, and then the lower it goes, the more severe the ARDS is. So how long do they continue shedding viruses? So the median number of days where patients are found to continue to have positive testing for SARS-CoV PCR is 20 days. Longest reported was 37 days. In most studies, the shedding continues until death in non-survivors, as we showed in a couple of slides previously. And then the shedding essentially means positive PCR. So it detects RNA fragments. It does not mean a viable virus. Meaning, if you do have a sample that's positive for PCR, it just tells you there is positive RNA. So there's evidence that this patient has this virus. However, we don't really have enough information at that point that says the patient is contagious. We assume they're contagious. However, to be 100% sure that they're contagious, you need to essentially get their sample, culture it in a virology lab where they have cell culture media. In case of SARS-CoV, it's vero cells is the ideal culture medium. And then you observe for cytopathic effect, cell destruction, positive immune staining for SARS-CoV, and that's how you confirm a viable virus, which is not something that's practical. The vast majority of hospitals do not have a virology lab. And so we usually use a negative PCR to determine that the person is not infectious anymore. So this slide actually nicely shows you the cytokines and how they go hand in hand with a clinical presentation. And so typically in a mild disease, you initially have the innate immune response trying to control the virus, waking up the adaptive immune response. The virus would initially start replicating, and then once the immune system interferes, the viral loads start going down, patients start manifesting a mild disease, and then they recover as the viral viral replication decreases and then eventually stops. And then with that, you have cytokines increasing, including interleukin-6, tumor necrosis factor alpha, and interferon gamma. And then you have with that CRP, D-dimer, creatinine may be increasing, and then eventually plateauing and improving. In cases of severe disease, it was noted that patients continue to have an exaggerated adaptive immune response. Viral replication continues. And then your interleukin-6 and other pro-inflammatory markers would continue increasing nonstop. And then patients would present with severe disease, ARDS, cytokine storm, hemophagocytic lymphohistiocytosis, with cardiac injury, high troponin, D-dimer, eventually ending up with shock. So based on the data that was available until January, the MOH COVID-19 suspected case definition was as follows. So essentially you had to have the correct clinical presentation in line with the reported clinical manifestations, in addition to an epidemiological link. So essentially an acute respiratory illness with sudden onset of at least one of the following. So fever, cough, shortness of breath, and in 14 days prior to symptom onset, so within the 2-week incubation period, you would want your patient to have had history of traveling abroad, traveling to identified hotspot area for COVID-19 in the kingdom. So that's something that you can, as you can see, is dynamic and changes from day to day. or close physical contact prior to symptom onset with a confirmed case, or working at a healthcare facility where there are confirmed cases. And so a case where you would not need any epidemiological link is when a patient presents with a severe respiratory tract illness, negative for influenza and MERS-CoV. So there are some cases of sporadic MERS-CoV, and so you need to confirm negative. And then you would still be left with a patient that's not getting better with no clear underlying cause, and then they'd fulfill a suspected case definition. So what are the complications to COVID-19 that are seen on the wards? So one of the interesting aspects that's gaining a lot of attention now is thrombotic complications in critically ill ICU patients with COVID-19. So some of the factors in terms of biological plausibility, why does this happen? So it is thought that severe inflammation, along with hypoxia, prolonged immobilization in the ICU and DIC would be underlying mechanisms that are probably related to why patients present with some thrombotic complications. This is a review that looked at 184 ICU patients. They had a composite endpoint, so they wanted to look at any thrombotic complication, whether venous or arterial. And in total, all in all, there were 31% documented complications, despite standard prophylaxis in all 184 patients. PE was the most common complication at 81%. Another complication that's gaining a lot of attention now is neurologic complications. So this is a cohort study that was published from China on a total number of cohorts, so total number of patients of 214. Any CNS manifestation occurred in about a quarter of patients, a little bit more in severe patients compared to non-severe cases. And then some of them manifest with relatively common CNS manifestations such as dizziness, headache, impaired consciousness. And then the concerning ones are acute cerebrovascular disease, so about 5% in severe cases, ataxia in one patient, seizures in another, and then peripheral neurologic manifestations such as tingling, numbness. There's also impairment in smell and taste, as well as vision and nerve pain. And so the proposed mechanisms for neurologic involvement is probably severe hypoxia can be a factor in developing an acute cerebrovascular accident. There's also the issue of coagulopathy and DIC in severe cases. And then there's also something that's being studied a lot is neuroinvasion. So there were cases all over Twitter talking about patients presenting with encephalitis-like symptoms, and then a CSF analysis would turn positive for SARS-CoV-2 and negative for other viruses known to be associated with encephalitis. But these are still sporadic cases, and we're still waiting for more data. So when it comes to treatment, what do we do? It really is impossible. It's almost impossible to navigate the evidence. Just going through PubMed, typing COVID-19 with title, you have 3,622 articles, and that's with COVID-19. Bear in mind that there are also other names that you can type in PubMed, such as novel coronavirus 19 and SARS-CoV-2, and this is just COVID-19, and it pulled 3,600 papers. The earliest was published in February because the term COVID-19 was used somewhat later after the viral outbreak was identified. And when you come to think of potential therapies for COVID-19, remember we talked about the viral structure and how it gains access to the host cell. So essentially you have this coronavirus with these spike proteins, these structures, so the S protein, attaching itself to the ACE2 receptor in lavender. And then there are other receptors that help ACE2 receptor in allowing the virus to gain entry. And so these are often, and there are multiple steps in viral replication and transcription, and then eventually exocytosis and then action triggering an inflammatory response. And so naturally, these are usually the targets. All of these steps are targets for different medications that would work on inhibiting the fusion, inhibiting entry, inhibiting transcription, so on and so forth. And so there's a lot of evidence on chloroquine and hydroxychloroquine. There's a lot of interest in using it. And so the mechanism of action, and so what is it biologically plausible? So number one, there's blockage of viral entry, if you look here. So it stops or inhibits the viral entry and endocytosis, and also endosomal acidification. There's also an immune modulation effect that's thought to act as well, where chloroquine and hydroxychloroquine alike inhibit cytokine production, lysosomal activity in host cells. We all know that hydroxychloroquine, also known as Plaquenil, is being extensively used in autoimmune diseases such as systemic lupus. In vitro, in comparison, hydroxychloroquine was found to be more potent compared to chloroquine. And so just to quickly explain these numbers, so essentially the lower number you have means you need a little bit less concentration to inhibit viral replication. And so essentially, this is the number of EC50 of hydroxychloroquine compared to chloroquine. And so there were simulation studies that were done to give you an idea of what concentration you would achieve within the lung lining fluid of the drug. And so it is suggested that a dose of 400 milligrams times 2 doses every 12 hours, followed by 200 Q12, would give you the necessary concentration. And then there's this widely publicized study, open label study, that looked at hydroxychloroquine use to reduce viral load. And so their primary endpoint was viral load in nasopharyngeal swabs. And then the title mentioned azithromycin, we'll come to that in a second. So essentially, the included number of patients was very small. So 26 in total were treated. 6 were set to be lost to follow up, and so they were not included in the analysis. 3 of the ones that were lost to follow up were actually transferred to ICU, so had a poor outcome. 1 stopped hydroxychloroquine due to nausea, and 1 died. And so these were deemed lost to follow up because there were no samples to check viral levels on. But we all know that these patients should be considered as failures. Instead, they were removed from the analysis, and only 20 were analyzed. Of those, 6 happened to receive azithromycin for whatever indication. And if you look at their clinical status, so essentially, majority had upper respiratory tract infections. And so patients that you wouldn't, in most countries, they wouldn't be even considered for therapy. And then, and also patients that were likely going to do well. And then pneumonia was only identified in 6 of these patients. And so that's essentially your cohort. And so there was a lot of criticism against this paper. It was widely publicized all over Twitter. A lot of people went to using hydroxychloroquine and azithromycin. The problem with that is one of the major problems is QTc prolongation on the EKG that you can see with both hydroxychloroquine and azithromycin. And so the number of prescriptions of hydroxychloroquine and azithromycin was huge, and there were some shortages in some countries as a result. And so this is another press release from the same group. They mentioned looking at 3,000 patients with improved outcomes, but again, no peer review, there's no paper. Once this is published, you have to examine the paper carefully and wait for an actual publication in a peer-reviewed journal. There's another paper that was published from China that looked at hydroxychloroquine, and they looked at virological clearance and progression to severe pneumonia, and there was actually no benefit in either endpoints. This is a leaked manuscript for a manuscript that was submitted and being reviewed in New England Journal of Medicine. Of course, we all know that papers that are being reviewed, reviewers are supposed to hold the information confidential. They're not supposed to discuss it. They're not supposed to leak it for sure. Again, it is unpublished, still under review, but the results were not encouraging for use of hydroxychloroquine. So what about lopinavir, darunavir? So the ID community knows that we use these medications as protease inhibitors for HIV therapy. And so the biggest trial that was published essentially randomized about 100 patients in both arms, so standard of care versus lopinavir, ritonavir, and then looked at mortality. And so the 28-day mortality was not different. And then most patients actually were initiated on therapy day 14 after manifesting symptoms. And so a lot of skepticism has actually surrounded this paper. And some of the questions were, was it because the patients were started late on therapy after manifesting with symptoms? Would it have made a difference if we had given these patients this combination within a week after manifesting with symptoms, for example, instead of waiting for 14 days? But what we do know from this paper is if you're starting patients 14 days after manifestations of symptoms, your 28-day mortality, your time to clinical improvement, and length of stay in ICU would not be different than if you didn't give them lopinavir, ritonavir. One of the other medications, so it's RNA polymerase inhibitor, is remdesivir. So there's a lot of attention, a lot of hope towards remdesivir. And so this paper was published a few days ago in New England Journal of Medicine. Remdesivir was being offered by Gilead, the manufacturing company, on a compassionate basis where any patient would require oxygen would be eligible. So they published their data on the patients that received remdesivir on compassionate basis. So about 53 confirmed cases have received remdesivir. All of them must have O2 saturation less than 94% for at least 10 days with no control arm. And so if you look at this graph, it essentially shows you the improvement in blue compared to death in gray. And they were categorized by severity based on oxygen requirements. So the ones on ambient air, so only 2 survived, no surprises there. The ones with low flow oxygen also survived. The ones on non-invasive ventilation, whether it's high flow oxygen or a CPAP or a BiPAP, did relatively okay. One of them ended up on an invasive vent and the other one died. Whereas with the ones with invasive ventilation had 80% death rate. So you might argue that 18% death rate is better than the 50% that you see in historical cohorts. However, you can't really make that kind of judgment without a control. And then the other thing to be kept in mind is that data that tells you 50% of patients on the vent die, a lot of them are on vasopressors, whereas this Gilead actually had use of norepinephrine or other pressors as a contraindication for approving remdesivir for use. And so we all know that patients that require pressure support tend to do worse in general. And so because of an interaction with norepinephrine, between remdesivir and norepinephrine, that was an exclusion criteria. And so essentially, this is a clean cohort that only is on a ventilator, but not requiring pressure support. So again, clinical improvement, more likely in non-invasive versus invasive ventilation. And then older patients tend to do worse, as we already know. And so in terms of remdesivir efficacy in severe COVID-19, no conclusions can be made. As of 2 weeks ago, there were 5 randomized controlled trials on clinicaltrials.gov to randomize patients for remdesivir. So we'll have to wait and see. And then IL-6 inhibitors. So there are two types of IL-6 inhibitors, tocilizumab and sarilumab. What they basically do is they bind to your interleukin-6 receptors, which are, so interleukin-6 are pro-inflammatory cytokines that are thought to be pivotal in the cytokine storm that's associated with poor outcome and high mortality. And so the thought is, okay, let's block the interleukin-6 so we can stop the cytokine storm cycle, and hopefully patients wouldn't develop such a severe ARDS. And so this is a cohort that was published from China on 21 confirmed cases. 17 of them were considered to have a severe pneumonia and 4 were critical. 18 of them received a single dose. The rest received 2 doses. And then interleukin-6 analysis was done on all of these patients and was actually quite high compared to your normal value of less than 7. 15 patients ended up having lower oxygen requirement within the first week post-therapy compared to nobody. So there's no control arm. So again, this is one of the major frustrations with publications related to SARS-CoV-2 that really leaves us very confused as to what to do with the results. Most of them do not give you a control arm. And if there's a control arm, it's usually with a retrospective study. So there's a lot of bias involved. If you go to clinicaltrials.gov and you just type in SARS-CoV-2, so it's the name of the virus, you have 657 studies as of yesterday that are essentially randomized trials that are looking at different therapeutic modalities and strategies and medications for patients with confirmed SARS-CoV-2. And so tons of studies ongoing. Hopefully recruitment for most of them will end soon, and hopefully we'll start hearing some results. And so in terms of treatment guidelines, again, this was published in January. For mild to moderate disease, recommendation is to treat patients with hydroxychloroquine, and then for severe disease, treat with hydroxychloroquine and consider alternative therapies such as lopinavir, ritonavir in patients that have high risk factors for mortality or factors related to poor outcomes. So essentially older patients, underlying comorbid conditions, cardiovascular disease, respiratory disease, diabetes, and cancer should be admitted to a hospital, whereas the rest can be isolated in a designated facility determined by the MOH. And so there are disclaimers, though, that there is no approved therapy that's known to work. So essentially, these guidelines are in line with the available evidence. And then you have to monitor for adverse events, probably most serious of which is prolonged QTC. One of the other modalities of therapy is convalescent plasma therapy. So for those of you who was following the Ebola virus outbreak, a lot of hype was given for the convalescent plasma therapy. Unfortunately, systemically, there was no consistent improved outcomes in terms of mortality with Ebola. When it comes to COVID-19, this is a cohort that was published again from China. So 10 cases, 10 severe cases that are confirmed, received different antiviral therapy. And so some received remdesivir, some received lopinavir, ritonavir, but they have also received convalescent plasma therapy. So it was a single dose of convalescent plasma. The plasma would be collected from patients that have recovered from their COVID-19, and they should have a titer. So the titer was determined to be 1 in 640. And the endpoint was safety. So they just wanted to make sure it's safe. And they compared them to 10 historical controls, and these controls were matched for age, gender, and severity of presentation. So in comparison, between the cases that received the convalescent plasma, 3 were discharged and the rest have clinically improved and were still in the hospital at the time of submission. And then compared to the controls, 3 died, 6 were stable, and 1 had clinical improvement. And so the results are encouraging, but definitely the numbers are too small to make firm conclusions. But it was enough to prompt multiple countries to start ongoing studies in several countries, including Saudi Arabia, for efficacy and safety of convalescent plasma collected from recovering patients to treat COVID-19. And so what about the use of steroids with what about the use of steroids to treat COVID? So this is a nice mini review published in The Lancet, where they looked at different viral pneumonias and the use of steroids to treat these pneumonias. And this is a paper on MERS that was published by Yassine Arabi group, where they essentially looked at the use of steroids versus non-steroids. Of course, it was a multi-center retrospective study that was comparative, looked at the use of steroids to treat critically ill patients with MERS. And the only difference was actually delayed clearance of viral RNA from the respiratory tract in the steroid-treated group. There was no difference on mortality. Same thing for the SARS-CoV different studies. So again, complications such as psychosis, diabetes, AVN in survivors were reported, and there was delayed clearance of viral RNA from blood. No difference in mortality. Influenza studies were concerning for increased mortality, and with RSV in children, there was no benefit. And so again, this was a meta-analysis looking at the use of steroids in influenza. Most of the results favored no steroids. And so there's another camp that's still advocating the use of steroids because, so the points they would cite is that these studies were all observational, so there is inherent bias. There are no RCTs. And so they're advocating the use of steroids only in cases of ARDS. There were some smaller observational studies that suggest possible benefit for certain viral pneumonias. And then the use of a small dose is advocated in some institutions to treat severe ARDS. As far as ECMO is concerned, this is the accepted manuscript for a surviving sepsis campaign that issued guidelines for COVID-19 management. And so it says here, we suggest use of veno-venous ECMO if available. It's a weak recommendation. There are no clinical trials on use of ECMO in COVID-19. There were some cases reported from China on the use of ECMO without reporting on clinical outcome. As far as ECMO and MERS is concerned, so this was a study published from Saudi Arabia on 35 patients with refractory hypoxemia, and that's where you essentially start using ECMO. Your patient has been on the vent, not improving, you're up against the wall, and so you use the ECMO as the last measure. In-hospital mortality was found to be less compared to no use of ECMO, but the issues that surround this study is that it's retrospective and there might be some selection bias. There are some concerns about increased bleeding risk. And for now, there's a registry that's collecting data on use of ECMO with COVID-19 with current prospective trials ongoing. And so the problems with ECMO is that they're very resource intensive. They're not available everywhere. There are some studies that mention better outcomes in centers with higher volumes on ECMO, likely related to increased expertise and comfort level in placing patients on ECMO. And so the practical question is that if you're hit with a large number of ARDS cases secondary to COVID-19, will it be practical and sustainable to use ECMO for these patients? Some of the other planned studies, this is post-exposure. So post-exposure prophylaxis in healthcare workers and high-risk patients. So some of the ongoing randomized placebo-controlled trials, some in North America, they're essentially looking at healthcare workers who have had an unprotected exposure to COVID-19 confirmed cases, and then they'd be randomized to either receive placebo or hydroxychloroquine, and then the participants would be followed to see whether they develop symptoms with confirmed COVID-19 or not, and that to be compared with placebo. And then high-risk patients such as elderly in nursing homes. And so these studies are planned to start soon. Some of them have already started recruitment, like the healthcare workers study. So unfortunately, the source for information with COVID-19 management has been Twitter, press release of non-peer reviewed data like the one I showed earlier on hydroxychloroquine from France, and then personal experience or anecdotes. I am guilty of the third one. We rely a lot on experience of centers or countries where they're hit with a large number of cases, and so we would essentially turn to them for guidance and for experience and to see what might be working, what might not be working. But again, they're anecdotes and based on personal observation. And because of that, you really have to be careful with what you see on the internet. A lot of it is inaccurate, unedited, unattributed, and juvenile. And so the quote is very correct. And so what do? So some of the unanswered questions related to complications, you need to compare to controls. And so there is an increased risk of thromboembolism, probably. But what about patients admitted with severe cases of pneumonia, whether bacterial or viral? Have we systemically looked at these? What about screening for complications? Does this mean that we should start screening every patient for PE or DVT, irrespective of symptoms, to avoid progression of the DVT to massive PE, for example, even if you're giving them prophylaxis? So there are side effects of imaging if you want to give contrast, like a CTPA. And then there are logistical difficulties involved with transporting patients to CT, doing a lot of CTs. There's a cost involved, there's radiation problems involved, and there's a potential exposure of healthcare workers as well. And what is the utility really of discovering tiny minor clots? How can neurologic complications be identified in sedated, mechanically ventilated patients? How can you pick up quickly a patient who's developing a stroke when you have them on all kinds of sedation so you can ventilate them properly? And then in terms of treatment options, how do you deal with a massive amount of information on the internet? So there has to be scientific plausibility. Things have to make sense. There has to be a scientific base to what people are trying to sell you in terms of information. You really need to wait for peer review. I understand that when you're faced with a critical patient on the floor, it's difficult to wait. But if you're going to read an unpublished or a manuscript prior to peer review, you have to make sure you do your own critical appraisal of the paper, and you have to read beyond the abstract. So what is the population being studied? Are they looking at patients that are probably going to be doing fine to begin with, like low risk factor group with asymptomatic or minimal symptoms? Who are they excluding? Are they excluding the ill ones, the ones that are likely going to do bad, and then they tell you their outcomes were good? What is the control arm, and what are they comparing their treatment to? The data need to be reproducible and consistent. When there's a lot of conflicting data on something that may be effective, and then in a different study may be associated with higher risk of ventilation, then that tells you there's something wrong, and you need more robust evidence. If you will treat with minimal evidence, you have to be vigilant, monitor closely for clinical response and side effects. You have to review your data in your own institution on a regular basis systemically in a table. Even if you think you know the data, you have to sit and review it, and you can communicate your concerns to policymakers. And with that, I'll conclude. Thank you very much.
Thank you, Dr. Sarah, for your really interesting presentation.
You're welcome.
Now we will open the floor for the audience for questions. So we received like quite a good number of questions, and anyone who have any further queries, please send it to the Q&A section. So we will start with our first question. This is really one of my favorite. I think we can get from this question like a take-home message. So it say, what do we really know for sure is working in terms of treatment for the COVID-19 infection for adult and pediatric patients? So what?
Thank you, Nada. So as I said, there's nothing that we know for sure. So that leaked manuscript to New England Journal of Medicine actually shows an association between use of hydroxychloroquine and increased requirement for invasive ventilation in patients that were not on a ventilator prior to starting hydroxychloroquine. So a lot of this can be due to chance, can be due to selection bias. And so this paper has not been peer reviewed. I did see some papers on use of interferon, different types of interferon beta with or without Kaletra that I reviewed for one of the journals. Again, there are a lot of issues with design, Neda. So a lot of them are not placebo controlled. A lot of them assume that interferon will be effective, but the question is, should we add Kaletra or not? So that puts you in a very difficult position in judging what would work and what wouldn't. And so do we know that this is better than remdesivir? Do we know that remdesivir is better than that? So unless there are head-to-head trials, it's very difficult to know. And so the short answer is nobody really knows. I have used hydroxychloroquine, but some patients didn't do well. And so it's very difficult to make that judgment call. Another thing with tocilizumab, we heard a lot of reports from colleagues in Italy and Spain about tocilizumab being very effective in patients that are about to become ventilated. But there are a lot of caveats involved. Do you have interleukin-6 level measured in real time that can support your hypothesis that this is likely cytokine storm or not? A lot of institutions don't have quick access to this information. And so they go with things like high ferritin, high LDH as a surrogate marker for a cytokine storm, but that's not typically enough. And so I think it might be reasonable to give hydroxychloroquine. Is it something enough to help patients that are critically ill? Probably not. You probably need a better therapeutic modality. There's a lot of hope with convalescent plasma, so we'll just have to wait and see.
Yes. Another question is, currently there are studies that are demonstrating that the effect on the lung is not really typical, the typical ARDS that we know of. And so the ventilation setting has been recommended to be different. So any comment from your side on this?
So this I like to leave to intensivists. What I do know is proning patients have been used extensively, recently at least. There are some reports on possibly permitting some form of hypoxia from Spain, but again, nothing has been published so far. Some of the issues with ARDS now, a lot of people are raising the question that most of your severe cases have bilateral infiltrates, and so nobody would ever image them for PE, for example. But there's also a question of, do they have subsegmental PEs that you can't see on an X-ray? And could this be contributing to their somewhat atypical ARDS form? I think, well, again, it's very difficult to say.
Great. We will take probably 2 more questions or as the time allows. So one question, you mentioned that that there is an association, actually patients with COVID, they have PE, but the question is if it is the other way around. So should patients presenting with PE at this era be screened for COVID?
So if there are ground glass opacities, then definitely. CT is very sensitive in picking up ground glass opacity changes in the lung parenchyma. And so again, some colleagues have indicated that patients would initially have ground glass opacities that are limited to some areas of the lung. And in a few days, they'd have bilateral ground glass opacities, more of your florid, typical viral pneumonia picture, and then their screen would turn positive. One of the points that I haven't mentioned during the presentation that I think are crucial is the lower sensitivity that's been documented with NP swabs compared to lower respiratory tract samples. And so if you do have a patient that's critically ill that is getting intubated, you really have to be sure that you collect deeper samples, tracheal aspirate preferably, if you don't want to do a BAL and expose everyone to an aerosol generating procedure. You have to be mindful of getting a deeper sample, even if you have a negative NP swab, if you're suspicious.
Okay. The last question, probably for the time, everyone, we know everyone has too many questions, but for the time being, so can you give us like an account on the HRCT management, I mean for the diagnosis of the COVID with or in place of the COVID-19 PCR, so swapping?
So I kind of alluded to that. So we were faced with some cases, and we were told about that from colleagues from Spain and Italy, and that was published in Chinese papers as well, that your patient would present with some symptoms, you'd be suspicious, your NP swab is negative, they get a CT. If you're highly suspicious, you're justified to do a CT, but you have to be very careful with maintaining patients under precautions. So when they're transported to CT, that should be done with precautions. They get a CT. If you see, so the typical presentation has been ground glass opacity, which may or may not be bilateral. And then if you're suspicious, then you're justified to keep the patient isolated and repeat the testing in a few days.
Great. To conclude, one question, how long are we expecting the COVID-19 outbreak will take place without an evidence-based management available?
I think it depends a lot on social distancing. I don't think this can be emphasized enough. And I think the measures currently taken in Saudi Arabia are fully justified, in my opinion. I think people have to do their due diligence. And the other point is, the more you see cases in the community, I think you should have a lower threshold for testing, because that is something that we saw with the MERS outbreak as well. And the MERS outbreak wasn't too long ago. And so we have to have our lessons that we've learned kept in mind. So a lot of patients would be presenting atypically. As we saw in the initial data, it showed 2 to 3% of GI symptoms with COVID-19, and now it's 20, maybe 50%. And so in patients that present with atypical symptoms and you're suspicious, I don't think there should be a lot of hesitation to test and isolate. And so there was a question about vaccinations, and the only thing I can say is the earlier trials in the US were unsuccessful. There are grants all over the world with millions of dollars that are looking at vaccinations. The only problem that I'm not an expert in vaccinations at all, or developing them, but the only problem that can sometimes happen is if you get a lot of viral mutations in the genome itself, that could be a challenge to find a vaccine that would work against it. And so one of the other important things that are being looked at is whole genome sequencing that's done at different time points for viruses and in different countries. And there are noticed different or genome variations that were picked up in Italy compared to China, so on and so forth. And so someone has to be mindful of that when they develop a vaccine.
Right. Thank you very much, Dr. Sarah. So actually there's too much to learn, as you mentioned, too many uncertainties. And the most important probably like takeaway messages here is to keep high index of suspicion, as you mentioned, be really vigilant and meticulous with the screening. And thank you for everyone who joined. Inshallah, on this Thursday, we will be having like exploring more and going more deep into the pharmacotherapeutic aspects in the terms of the probable complication, side effect, drug interaction for the COVID. And we will be talking about the other aspect other than the treatment. So hopefully, again, we will continue this series and we will be all learning from each other. Thank you, Dr. Sarah.
Thank you.
Thank you very much.